much, Sophie. I'm a cardiologist at the Ulster Hospital in Northern Ireland. This is a hospital that is, in NHS terms, considered to be a district general hospital, but it has increasingly evolved to have a university teaching role. We serve a population of about 450,000 patients, and we have a very active cardiac radiology unit. We've been quite fortunate, and I do point to these two pictures in the bottom left, to be going through a restoration of our old NHS capital estate. So on the right-hand side, that was the building I took up post in some 10 years ago. And on your right-hand side, that's the building that I'm currently working in. So it's really rather impressive. So I started my involvement with cardiac CT way back in 2003, and there are some culprits in the room who really helped me in that very early part of my journey. You will recall with 16 multi-detector CT technology, it really revolutionized our understanding, but with it came some challenge, not least technical challenges in terms of scan acquisition, hardware challenges in terms of motion and breathing artifact, and radiation dose challenges, which were really quite high for 30-second breath holds in patients. And we were really trying to feel our way around. Over the last 10, 15 years, there's been fairly substantial improvements in both our hardware and our software. But all of these improvements have really focused on providing us with a multi-purpose system, much of which I don't understand. I'm a cardiologist, so I do echo using an ultrasound probe that's dedicated for echo and the cath lab. I've got a fluoroscopy tube that focuses very solely on the heart, and I know very little outside of the heart. But I do know a few things about what I need to be doing for my patients. Within the United Kingdom, the National Institute of Clinical Excellence, or NICE, is our body that really has a look at how we can provide cost-effective, high-quality care for our patients. And in 2010, they reviewed how we assessed patients with stable chest pain that was suspected to be of coronary artery disease origin. And at that stage, they gave some lukewarm approval to the use of cardiac CT technology and the evaluation of those patients, not least because at that particular juncture, we were still on 64 detector technology, and there were still some significant limitations to good, robust practice. In 2016, NICE issued an update just towards the end of last year, 2016, rather than 2017, where they basically got away with chest pain characterization, which you spend an awful lot of time on and get wrong most of the time anyway. And they suggested that we could maybe use technology in a new way whereby it could triage our patients that are deemed to require investigation for suspected coronary artery disease. And as such, they said the 64-slice technology was a good technology to use as a first-line gatekeeper investigation for patients with stable chest pain symptoms. So it's a good thing in theory, but in practice, we've had some significant challenge in terms of implementation, not least access, resources, and competencies. We know that CT now has become the workhorse of any busy district general hospital across Europe. And in fact, these are figures from NHS England just last year that shows nearly an 8% year-on increase in the need for access to CT technology. If you take a look at the bottom part of the screen as well, we're competing with other subspecialty groups for access to CT time, not least the need to replace barium enema with CT colonography. So this is a recurring theme. So how does cardiology get to the table? The BSCI, our national body, issued a report that took a look at our 2015 figures and what it would mean for us in the United Kingdom to try to implement CG95 guidance. In 2015, there were approximately 40,000 cardiac CT examinations performed in around 101 centres. Nearly a third of these were performed in 10 top performing sites that had dedicated access to cardiac CT. Nearly 90% of our cardiac CT service were delivered in low volume district general hospitals, which were fortunate even to be doing about 10 CT scans a week. So we're quite a long way off in terms of implementation of these guidance, not least in terms of access, skill set, and time on the scanner. But I think our argument for trying to do things differently with cardiac CT mustn't only be an argument of access. We have to look at cost. We continue to prop up a system that uses multiple imaging tests and quite significant downstream resource utilization to evaluate someone with chest pain. Very often these patients, 30 to 50% of them that come through our rapid access chest pain clinics in the United Kingdom could have normal coronary arteries. So very little is needed. So we're exposing them to additional radiation dose, additional concern. So there are real safety issues if we continue to perpetuate the old investigative paradigm that started with Braunwald 30 years ago. Over the last number of years, we were really starting to see how cardiac CT can really improve outcomes for our patients. And there's information that we currently don't use on our CT data set. Our patients don't have access to get that information on their data set that could really improve their outcomes. Addison, Promise, and of course Scott Hart have all suggested that it's non-occlusive coronary atherosclerosis, which we would pick up opportunistically at a rapid access chest pain clinic that uses CT, actually correlates more closely with the patients who are likely to have events. So I think in the Promise study, it was non-occlusive coronary artery disease that resulted in about 60% of the events, and yet we ignore it at present. With medication, with appropriate primary prevention strategies, some early trial data suggesting we could reduce outcome, we could improve outcomes and cardiovascular mortality by as much as 30 to 50%. So that's my thinking around why I'm moving towards a cardiograph type system. GE have a pedigree in this world and already are delivering very good whole body system scanners that can also deliver very excellent high quality cardiac CT. Cardiograph is really the first in their stable, along with Araneta, that is focused on delivering cardiac imaging. For me, the big challenges with cardiac imaging over the years has been we lack sufficient temporal resolution. High image quality is it can be difficult to achieve without very close attention to detail, and low radiation dose is absolutely key to any new CT scanning modality. So what is the cardiograph? Well, it's a whole heart coverage system. It's a single heartbeat acquisition. It is an average scan time of about 0.12 seconds. It's focused on the heart, but for a cardiologist, it sits very nicely within our existing estate. We have a CT scanner that occupies less floor space than that is mandated for us to put a transthoracic echo machine in a room, which is pretty impressive. And the gantry weight doesn't require huge structural load-bearing floors to be installed because it's about half the weight of any other existing CT system. So you're all familiar with these images of fast gantry rotation times. But one of the things that we really like about this system, at 0.12 seconds, we probably can start to push our threshold for beta blockade slightly higher than we had been doing previously. And that has a knock-on effect in terms of patient flow and process through the scanner. It was very important for our system to try to achieve as low as reasonably possible radiation dose. So sub-millisievert to less than 3 millisieverts for a standard CT coronary angiogram. And image quality must be good. And with a full volume coverage, we have less cardiac motion. We have a very short breath hold time. There's no stitching artifact, and that is an implication for reconstruction and advanced post-processing techniques that we're increasingly using, such as FFR. And heart rate variability, which can so often throw us, is no longer an issue. Just going to share with you some of our initial images. Obviously, I'm going to show you the best images. So this is one of the first patients that we put on the scan, a lady presenting with atypical chest pain, good heart rate, but we were able to achieve a 0.5 millisievert dose. So we're able to get really low dosages in very specific patient groups. Again, another patient, slightly larger patient with a slightly higher heart rate, and again, the heart rate slowed very quickly during the scan itself, and as a consequence we had to flip phases to try to get diagnostic image quality, and the scanner gave us the flexibility to do that. This is an acute patient who presented to our emergency department with a typical chest pain. He's very anxious, describing unusual pain. And it's very difficult for me to say whether this chap actually had angina. In fact, what we identified was bystander but significant coronary artery disease. You can appreciate just that the ostium of his ramus intermedius is a really discrete but tight non-calcified plaque stenosis. And there was some evidence of a perfusion abnormality associated with that. We can also do heavier patients. You'll be aware the cardiograph has a slightly narrower aperture than some of the other CT systems. I think we're 60 centimeters, but with that we're able to still get very good image quality. This is someone who has a BMI of 39. We have been imaging coronary artery anomalies in the last 3 weeks, all just people who came off the street. So this is a benign retroaortic left circumflex coronary artery. We've been having a look at some stents, and with our high resolution protocol, we're really able to get very good image quality. And finally, just on Friday, we did a patient who was in atrial fibrillation with a heart rate that varied from 80 to 110 beats a minute. Very ill patient on the ward with infective endocarditis, and we'd chosen not to take her to the cath lab for obvious reasons. And as part of the preoperative assessment, we wanted to be certain that there was no significant concomitant coronary artery disease that would need to be treated. So it was a very nice one-stop shop for that particular patient and a very complex patient. Kanamaterian Heart has suggested that we really should be considering urgent pathway reform for cardiac CT, and there's no reason why, with a dedicated system such as this and the use of advanced algorithms such as FFR, that we should be getting to a position where we should be able to provide a one-stop shop for these stable patients with chest pain. And this is the pathway reform that we're going to try to mimic in the Ulster Hospital over the coming months as we try to establish the service. I wouldn't be able to show any images at all to you without the help of a very advanced and experienced team, and I want to say a big thank you to all of them for their help over the last 6 weeks in getting the scanner installed and the first clinical patients through. Thank you.